today. My name is Eileen Michelli, and I am the Chief Program Officer for the Marfan Foundation. And we're thrilled to have you all here participating in the International E3 Summit, Educating, Empowering, and Enriching Our Community, which is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at CERN. We are really grateful to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. Before we start the presentations, I just have one little point to share with you all. I wanted to let you know that the International Summit is a forum to provide discussion of the issues related to genetic aortic and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or CERN. If you hear different opinions from different speakers in your sessions over the next couple of weeks, you can send your questions and ask for more clarification from our help center. And that will be at marfan.org/E3ask. And we will put that in the chat box, and we'll also have that on the screen later on today. So today, like I said, we have Dr. Leroy and Dr. Kreps. So the three of us are going to shut our cameras off, and we're going to give you these two presentations, and then we'll be back shortly for all your questions. And there were tons of questions in the Q&A box, and we will be getting them right after these presentations.
Hi, I'm Bart Leroy, a clinical ophthalmologist and a clinical geneticist from Ghent in Belgium and Philadelphia in the USA. I'd love to talk to you about ophthalmology basics, the eyes in Marfan syndrome and allied disorders. What are the symptoms and signs? Let me first take you through the anatomy of the human eye. The cornea is the hourglass of the eye at the front. It is transparent and a rather strong lens. Just behind it sits what we call the anterior chamber. In the anterior chamber angle all around, liquid is drained from the eye. That liquid is produced just behind the iris in the ciliary body. This is the iris or colored bit of the eye. In the middle, there's a pupil or a hole. Just behind the iris sits the lens. The lens, together with the cornea, form the lens system. These two together focus what we are looking at on the back of the eye, the inner lining of which is called the retina. The retina translates light into electrical signals that are then sent to the back of the brain through the eye nerve. One specific aspect of the eye that I have to highlight are the zonular fibers. These are small threads that actually suspend the lens in its capsule. These zonular fibers, as they are called, contain a lot of fibrillin encoded for by the fibrillin-1 gene. Let's first look at the ocular characteristics in Marfan syndrome. Eye abnormalities are seen in a fairly large number of patients that are initially seen by eye doctors. Fibrillin-1 is found in nearly all of the ocular tissues, and so it's therefore not surprising that eye abnormalities are a part of Marfan syndrome. Most of the issues relate to ectopia lentis. Let's look at that. Ectopia lentis, or displacement of the lens of the eye, was first described already in 1914 in Marfan syndrome. Marfan syndrome is also the most prevalent cause of ectopia lentis. In 273 cases of ectopia lentis, as studied by Fuchs and Rosenberg in 1998, 68% had Marfan syndrome. Other ocular signs and symptoms are lens colobomata. Those are abnormalities in the formation of the lens at the bottom, a flat cornea, an increased axial length, glaucoma or high-pressure disease of the optic nerve, retinal detachments, they need surgery, myopia or the need for negative glasses for proper focus, and then cataract or cloudy lenses are more frequent in Marfan syndrome patients than in standard people. The Ghent nosology, as revised in 2010, includes lens dislocation or ectopia lentis, as well as myopia of more than 3 diopters. The ocular nosology group that sat together in 2006 and 2007 reflected on what was important in Marfan syndrome. An ectopia lentis, or the dislocation of the lens due to zonular fragility and/or rupture, is obviously very important. There's a grading. It's either present, it's inconclusive, or it's absent. And the value of luxation, the lens that is really falling into the back of the eye mostly, or subluxation, the fact that it is displaced, is equal in its diagnostic value. How do you look at this? You basically make sure that the pupillary dilatation is larger than 8 millimeters at a minimum. You have the patient look down and you use retroillumination. The axial length is oftentimes increased, as we will see. This is, for example, an image where you see the border of the lens in a normal picture, but once you look, you use retroillumination, that is, you project light into the eye such that it reflects on the back. The back is the red retina. It gives you a higher contrast image for you to better see the border of the lens, as you can tell here. This type of technique shows an inferior lens coloboma in this patient. The patient also has vascular tortuosity or corkscrew abnormalities of the retinal vessels, as you can tell from this image. Another patient with a minimal lens subluxation, and a patient with clear lens subluxation and an abnormal lens shape. In this picture, with high magnification, you can tell the zonular fibers. These are those little threads that hold up the lens 360 degrees all along the lens. They rupture, are of worse quality, they contain a lot of fibrillin, and that's why they're affected in Marfan syndrome. This is a young boy, 8 years old, with a lens subluxation, as well as an abnormality of the optic nerve head, as you can tell from here. The Berlin, Ghent, and again the Ghent criteria, 1986, 96, and 2010, all feature ectopia lentis as a important, called cardinal feature in 2010 of what is Marfan syndrome nosology. You can tell from the bottom part of this table that the eye signs and symptoms are less important as time progresses. We looked at a patient population in Ghent. Group 1 that we looked at from the Department of Ophthalmology were 114 patients with presumed Marfan syndrome, 76 of whom are fibrillin 1 mutation positive. A second group from the Center of Medical Genetics were 209 patients with ectopia lentis. They were probands referred for fibrillin 1 mutation analyses due to the fact that there was ectopia lentis. How many of the fibrillin 1 positive Marfan patients have ectopia lentis, have myopia, have flat cornea, have increased axial length? Let's look at that. Here you see the ectopia lentis and fibrillin 1 status in 114 presumed Marfan patients. 76 of these patients had a mutation in fibrillin 1, and 80% of the patients have some degree of lens subluxation. But when you look at discrete lens subluxation and a visible inferior lens border, and you then look at how many of the fibrillin 1 negative patients also had this, the value of discrete lens subluxation and visible inferior lens border becomes questionable. What about myopia? 61% of Marfan syndrome patients with a proven fibrillin 1 mutation are myopic. What about axial length? The jury is still out. We don't really know whether there's a difference between fibrillin 1 positive and negative patients. And this is the same for the corneal status. Are there more flat corneas in fibrillin 1 positive patients or not? We don't know yet. More work is required. Things we learned from the second group is how many patients with ectopia lentis referred for fibrillin 1 analyses are actually fibrillin 1 positive. Well, 209 probands were looked at in ophthalmology, and 157 out of 209 patients, or 75%, had mutations in fibrillin 1. Of 52 others, biallelic mutations were present in ADAMTSL4 in 4 patients, LTBB2 in 1, and ADAMTS10 also in 1 patient. What are the conclusions for Marfan syndrome from what I've been telling you? Discrete lens subluxation is not helpful to make a diagnosis of Marfan syndrome. The jury is still out on axial length and flat cornea. Axial length measurements and keratometry, or the measurement of the power of the cornea, which will tell you whether it's flat or not, are required to correctly interpret myopia. Anterior chamber angles should be studied in Marfan syndromes and the other conditions, and a lifelong follow-up is required. Let's look at ectopia lentis at pupillae. What is this? This is a recessive condition, not dominant like Marfan syndrome. Lens subluxation with a pupillary displacement opposite to that of the lens is seen when there is pupillary displacement. It's not always the case. Sometimes there's only lens subluxation. There are no systemic features, and ectopia lentis and ectopia lentis at pupillae may occur in one family. Biallelic mutations in either ADAMTSL4 or LTBB2 lead to this condition. Here you see one individual from a family, a normal-looking right eye, an abnormal-looking pupil in the left eye, as you can tell. But once we dilate, we can also see an abnormal lens in the right eye that was presumably normal. We can definitely see a cataractous displaced lens in the left eye. There are abnormalities of the anterior chamber angle. There are abnormalities of the back of the eye. This is an LTBB2 positive patient. The previous patient was ADAMTSL4 positive. And you can tell from these images that there's a clear lens subluxation. Cohen syndrome is another condition that leads to possible ectopia lentis. It's not present in all, but it is seen in some. Also, retinal dystrophy is present in this condition. It's infrequent and it's due to biallelic mutations in Cohen syndrome 1 gene. This is, for example, an image of both right eye and left eye. Seen is in both images a upward displacement of an abnormal lens. This is the lady. She also has retinal dystrophy at the back of the eye. Other syndromes include Weil-Marquesani syndromes. They have microspherophakia, or small thickened lenses that actually can be displaced. Homocystinuria oftentimes has an inferior ectopia lentis. Trabulsi syndrome, as seen in these 2 images, leads to ectopia lentis with some other anterior segment abnormalities. And in Lewis-Dietz syndromes, you can see myopia, you can see cataract, retinal detachments, but recently there was also abnormalities of the blood vessels described. The general conclusions for the ocular characteristics in Marfan syndrome and ectopia lentis syndromes is that we need an experienced ophthalmologist. We need a surgical approach that can be variable between ophthalmologists, but that really has the complex issues of a Marfan syndrome eye or any of the other conditions in mind. Yearly follow-up visits are always required, and serial slit lamp photography with retroillumination can have you follow up the ectopia lentis to see whether it evolves or not. It normally does not evolve quickly. An evaluation in down gaze after full pupillary dilatation is required. as is a retinal evaluation after pupillary dilatation. Why? To look at tears in the periphery of the retina, which may lead to retinal detachment. Obviously, I do not work alone. I wish to acknowledge the people listed in this slide. Thank you very much for your kind attention.
Thank you, Dr. Leroy. And now we are going to go to Dr. Kreps, if I did that right.
Hi. I'm Elke Kreps, and I'd like to talk to you about the eyes in Marfan syndrome and allied disorders, novel findings and treatment options. Now, the research within the field of Marfan syndrome and the eye has mainly developed a main hypothesis on how abnormal fibrillin results in the various ophthalmic features you see in Marfan eyes. And that hypothesis includes the concept of a generalized globe expansion that happens in Marfan eyes, where you can see that the eye itself is longer than an average eye, and that the cornea, which is the front clear part of the eye, is flatter and thinner than it usually is. And the same thing occurs at the level of the sclera. So the white part of the eye, it is also thinner and it is flatter. So in that way, it somewhat resembles what happens at the level of the aorta. Now, one of the most important features, if you look at the eye in Marfan syndrome, is the occurrence of ectopia lentis, or a lens subluxation. Now, the crystalline lens, as you can see here, is usually suspended in place by threads called the zonular fibers. And these zonular fibers have very large concentrations of fibrillin. And the function of those zonular fibers is what you can compare the springs of a trampoline with. So it is basically meant to keep the lens nicely in place, nicely centered at the level of the visual axis. Now, what happens in Marfan syndrome is that these weak zonular fibers actually cannot keep the lens nicely centered, and the lens tends to dislocate towards superior and towards the side. Now, this can be quite subtle. As you can see here, you can see the inferior border of the lens. So this lens is a bit more upwards than it should be, and it can be quite pronounced. As you see here, these are all stretched zonular fibers, and the lens actually is dislocated quite far. Now, the next question, if you are going to look at the management of ectopia lentis, the next question is, when do you actually need to proceed to surgery? Well, the situation is a bit different if you look at adults and if you look at kids below the age of 10. So in adults, you either will proceed to surgery if the lens has become cloudy, which is what we call cataracts, or if you're no longer able to get a sufficient vision because the lens is either completely dislocated or it bisects your visual axis, or your pupil, and causes you to have a bothersome double vision that you see two images, as you can see here. But that's the situation in an adult. In children, the situation is a bit different because below the age of 10, your brain learns how to cooperate with the eyes and learns how to communicate with the eyes. If one eye has a good quality of images and the other doesn't, your brain will learn how to collaborate with the eye that has good quality images, and it will just neglect the other eye. And that's how you develop what we call a lazy eye or an amblyopic eye. And this is actually a process that you can only change within those first 10 years of life. And afterwards, that eye will always remain, so to speak, lazy, and you will never be able to get a better vision out of that eye because the brain just has not learned how to use the information from that eye. So your threshold to proceed to surgery will actually be lower in children because you know that within those first 10 years, the development of the eye and the collaboration with the brain is very important. And if you miss that window of development, you can never go back. Now, if you decide that surgery would be the best option, then the next question is, how are you going to do it? Because in classical lens removal surgery that we do for cataracts, what we do is we remove the front circle of the lens capsule in which the lens matter is located. We only open the front of the capsule because you want to keep that capsule intact to put the artificial lens in once you have removed all of the lens material. Now this, of course, requires that you have a normal lens capsule and that you have zonular fibers that actually keep that lens capsule in place. So you can imagine in Marfan eyes that this is not going to work. So historically, there weren't all that many options. If the lens was bothersome, you could remove it. And the typical way of doing that was from behind the lens, just eating it out and removing everything. Zonules, the capsule, the lens matter, just everything. And either put a lens in front of the iris, which you see here, which is an anterior chamber lens, or you just don't put a lens in, and then you have quite thick glasses afterwards. Now, this was surgery that was troubled with quite a number of complications, and the problem with these types of lenses as well is that it's not actually firmly attached to any of the structures. So if you, for instance, put this lens in a kid, the kid is going to grow and his eye is going to grow as well. So that lens is going to become unstable once the eye has grown. So it wasn't an ideal solution. Now, luckily, we've now have a number of devices that can help us both during surgery and new types of lenses that can help us. Now, one of the very nice surgical aids are what we call capsular hooks. Now, these are blunt devices that you can use to hook the rim of the capsule once you've made this circular opening in the capsule, and this actually effectively replaces the function of zonular fibers during surgery because you put it in place to actually suspend the lens and its capsule to the eye wall, and that way you actually get support to remove the lens without damaging too much of the structures surrounding it, and without having the risk that the lens will just drop to the back of the eye while you are trying to remove it. Now, a second nice technique, once you have to put the lens in, but you know that the zonular fibers are not strong enough, you can actually put this ring device in, and this has additional hooks which allow you to put a suture in on these two sides, and you can actually see this here. So this is where you put a suture in, and you attach the ring to the sclera in order to keep the lens capsule nicely centered and nicely stable. You can actually see this here. So this is actually the artificial lens, and this is one of those hooks that you see here with a suture through it. So this actually allows you to put a normal type artificial lens in within the capsular bag in its normal position, nicely centered, but with the additional support of those two sutures, so that you actually get the additional support that you need to support the weaker zonules. So this is an option in cases that have fairly mild subluxation and have a sufficient amount of zonules that are still well. Now, in cases that you can no longer use the capsular bag because the zonules are just too damaged, you have two other options. After you've actually removed the lens, you can put an iris claw lens or an iris clip lens, in which you just clip the iris. So this is the artificial lens, and you take a bit of iris tissue to clip it underneath, and that way is nicely attached to the iris. Now, it's alternatively, you can also actually attach it to the sclera, and then you put some sutures in here. Now, there's been a number of studies on which one of these techniques are actually the best. Now, the thing is, we don't actually know as of yet. There's no real consensus, and it very much depends on the eye and on the status of the zonular fibers on what you could best do. When you compare the fixation to the iris to the fixation to the sclera, you tend to see that in longer follow-up, the scleral fixated lenses tend to dislocate more frequently than the iris clip lenses or iris claw lenses. Now, this is probably because the shape of the sclera is also different in Marfan eyes as compared to normal eyes. So we know that it is flatter, and the overall shape also differs from that of normal eyes, which is probably one of the reasons why these lenses dislocate more frequently in Marfan eyes as compared to normal eyes. Now, either way, no matter what type of surgery you are having, the surgery itself does increase your risk of developing a retinal detachment. So it is very important to have a regular checkup, at least every year, to actually check the retina. Now, why is that important? That is our second topic of today. Retinal detachment occurs more frequently in Marfan eyes, and especially in Marfan eyes with ectopia lentis. And that's because two things occur more frequently in Marfan syndrome. So you have a high recurrence of peripheral retinal degeneration, which actually leaves you at risk of developing retinal tears or retinal detachment. Also, a process that you see in every single person and in every single eye is what we call liquefaction. The vitreous jelly actually fills the largest part of the eye, and it becomes more liquid as you grow older. And that liquid at some point actually causes this jelly to detach from the back of the eye as what we call a posterior vitreous detachment. This occurs in every single eye, but eyes that have weaker peripheral retinas may develop retinal tears because of this detachment of the vitreous and of abnormal vitreous connections to the retina. So we know that retinal detachment occurs more frequently in Marfan syndrome, but luckily the outcomes these days of retinal surgery are exactly the same in Marfan eyes as compared to normal eyes. So the main thing is to be vigilant, to have regular ophthalmic checkups so that these degenerative areas can actually be located and can be treated by laser treatment so that it does not end up in a retinal detachment. I'd just like to acknowledge and thank a few of my colleagues, both in Ghent and Antwerp, who are very much active in both the clinical follow-up and the research part of ocular findings in Marfan patients. And I hope you've enjoyed this little dip into the wonderful world of ocular findings in Marfan syndrome. Thank you.
Wow, that was great. We heard two really great experts there from Europe. And so now we're going to go into the questions and answers. And I know you all have so many questions and answers. I'm going to stop sharing my screen so that you can all see Dr. Kreps and Dr. Leroy. There you go. Hopefully you can all see them now. And so there's a lot of questions for you guys. I hope you're ready. A lot about lens implants, and we're going to start with that because that was really the most popular question here. People want to know, you know, what are the advancements in lens implants in the last 10 years? And the question is, is there ever going to be a real possibility with good outcomes for people with Marfan? So Dr. Leroy is shaking his head yes, so we'll start with him.
Yeah, Eileen, what we can do, we can actually, and this is for everyone who's online, we can actually see through the little app on my iPhone, we can see the questions. So basically, I'll let Elke answer this one because she's actually spoken about this and maybe she has something to add.
Yeah, so if you look at what has been the advances in the past 10 years, those capsular hooks that I showed you during my talk and the ring segments with the possibility of suturing a ring segment and a lens to the lens capsule and to the eye wall. These are all things that did not exist 10, 15 years ago. So we definitely are heading towards more options to actually save or keep the lens capsule and use different ways of actually stabilizing the lens capsule to the eye wall by using sutures, by using rings that you place in the lens capsule. So that those are all essentially ways of actually replacing the normal function of the zonules by, be it sutures, be it a ring or both, to make sure that you actually can insert a lens on the normal place that you put a lens when you perform traditional cataract surgery. So we are definitely heading towards improved outcomes. The number of patients that have been treated in that way are still fairly limited because these are quite new techniques. So we're probably gonna only notice in 5 to 10 years how much improvement these new techniques can actually make in the outcomes of the eyes. Because if you look at all of the different techniques that are there, like all of the different ways of fixating lenses to the sclera. So we've seen a number of questions as well about different techniques, different ways of suturing the lenses to the sclera, or using glue, or using different techniques. Now, all of these techniques, they are very demanding techniques for a surgeon, and it very much depends on just the experience that an individual surgeon has with the technique, on how high the success rate is going to be. So we're definitely heading in the right direction. And one of the additional things that we are using is actually using the same laser that we use for refractive laser surgery. You can actually do part of the cataract surgery with that laser to limit the amount of stress that you actually put the zonules in during surgery, because when you remove a lens, you do actually have to push and pull quite a bit in the eye, which causes additional stress. And using a laser to do parts of the surgery can actually save a few of those zonules and increase your chances of actually being able to keep the lens capsule, and in that way put a lens in place that is going to be more stable and nicely centered. So there definitely have been, part of my talk was all about those advances that have been made over the past 10 years, and probably there are going to be even more techniques, actually just different ways of replacing the normal zonules and different ways of stabilizing the lens to the sclera or the iris.
Great, thank you. Dr. Leroy, did you want to take a look at the questions in there since you're watching them, or you want me to go through them?
I can help out indeed, and we can be more efficient.
Sure.
You don't have to read them. So I can read the next question. Is it still considered unsafe for someone with Marfan to have laser surgery for myopia, even if there have never been lens dislocation issues? So again, I can say that it's not by definition unsafe. I think that Elke, as a cataract surgeon, cornea specialist, amongst other things that she knows very well, can add to that. So it's to wrap it up from the start onwards, we can say that myopia surgery is not by definition unsafe, but there are a couple of caveats, and Elke can comment on that maybe.
Yeah, so what we know about the cornea in Marfan syndrome is that it tends to be flatter, it tends to be thinner, and we assume that it is less solid, less strong than a normal cornea. Does not mean that you cannot do laser surgery. It just means that you need to be a bit more careful, and you will be able to treat less diopters of myopia than you would in another patient, because you start off with a thinner cornea and you need sufficient amount of corneal tissue left to have a stable cornea. There's been some hypothesis that using the docking system that you use in order to perform the laser surgery, that may actually enhance a pre-existing lens dislocation. Now there's no proof that if you don't have any lens dislocation, that the actual performance of the laser surgery would actually induce it in patients who don't have it from the get-go. So basically, to wrap it up, you just have to be extra careful and have to be very thoroughly evaluated to be sure that if you do the surgery, that you don't have any amount of dislocation from the get-go, and that you will have sufficient corneal thickness left after the surgery. If that is okay, then I don't see any problem to go ahead with it.
I think I fully agree what Elke's analysis is on as a reply to this question. The thing to add is most eye doctors are serious people. I would tend to go and seek advice before getting this done, not necessarily from a fairly commercial practice that does patients in series. That is not to say that those centers are not of excellent quality, but it would be best to get maybe an opinion from someone who is aware of what Marfan syndrome poses as a challenge, in the sense that, as Elke was saying, the docking system, basically for you guys who don't know what refractive surgery is at the level of the cornea, and I assume not all of you know, you basically use a suction ring to actually dock onto the front of the eye. And then what you do is you actually excise or you cut into part of the cornea at a certain level in the thickness of the cornea, and then you open up that cornea, just like you would the lid of one of those waste baskets or bins, and then you actually perform laser, and that reshapes and mostly loses tissue from the middle area of the cornea, and then you close it down again, you close the lid again. And so Elke was talking about docking the system on to be able to use the cutter that actually is on a rail on the sucking system, or the docking system that sucks itself in place. And obviously these mechanical pressures exerted on an eye can be a little bit more dangerous in people with Marfan syndrome, with the pressure also exerted on a zonular fiber system that isn't perfect, as we know. So we can, in the interest of time, we'll move on to the next question. And the next question is, should you wait until your lens completely displaces to have surgery, or do it when it quickly progresses towards that point? And maybe I'll give my colleague Elke again the floor to comment on that. I know what she's going to say, but I'll let her say this.
Yeah, the decision about if you should proceed to surgery or not, it mainly depends on whether or not you're still able to get a good vision from that eye with traditional optical correction. So there are spectacles or contact lenses, or mainly those two. If you get a good vision, even though your lens is a bit dislocated, there's no firm indication to do the surgery. However, if you have bothersome double vision, or if your vision drops to a point that is below what we typically use as sort of the demarcation, if it drops below 5/10 vision, or 6/12 vision, depending on how you in what measure you,
or 20/40
yeah,
in America.
There you go. So if it drops below that rate, or if it's bothersome when you look with both eyes simultaneously, then that is an indication for surgery. If you wait until your lens is completely dislocated, that also means that you have no zonular fibers left. So that means that you cannot use any technique that will save the lens capsule and save the remaining zonules, like those ring segments I showed you with the sutures in. You can't use those techniques if you wait until it's completely dislocated. Not as to say that if it's not bothersome that you have to do surgery to be able to use those techniques, because iris fixated lenses can provide a good result, but you don't necessarily have to wait until the lens is completely dislocated if it actually bothers your vision.
And mostly it is going to bother your vision as it reaches about the point of half dislocated. Then obviously you're going to suffer visually. And so there needs to be that cutoff, and the cutoff that Elke was talking about, 5/10, 20/40, 6/12 vision, depending on Europe, continents, UK or the US. About half of the classic best corrected visual acuity is the lower limit of what is allowed to be legally driving a car. So that's for us a cutoff in our busy world where personal mobility is important. So we'll move on to the next question, and the next one is for kids. 4-year-old in our case is the recommendation to remove clear but dislocated lens, more than 50% dislocation, without putting implants in place. Is there a possibility for implants in the future? And I would say probably your 4-year-old will have some considerable impact on best corrected visual acuity, and obviously at that age your child is forming the visual pathways, and so if your brain doesn't learn how to use one eye, we call that condition amblyopia. And so you must be wary of whether there's no permanent immaturity there of your brain using that eye less than the other one. An eye without a lens corrected with a contact lens can be perfectly okay. And it really depends on matters like axial length, which is the total length of the eye, about what you do. Can secondary implants be placed after the eye is approximately adult size, which is about 13, 14 years old, and an eye is approximately at the adult size? Yes, of course, and I'll let Elke actually add to what I've been saying.
Yeah, so the setting indeed, if you look at a 4-year-old, is different than the setting if they're 12 years old, because of what Dr. Leroy just said. You've got the risk of amblyopia. So if you have a poor vision in an eye at the age of 4 and you don't do anything about it, and you would only potentially do surgery when they're 12 years old, then you know that you can no longer improve the vision to more than what it was at that age, because your brain has never actually learned how to use the visual input from that eye. So the threshold to actually perform surgery in that age group will actually be lower than in an adult, because you kind of know that this is sort of, you're increasing the potential of that eye. In a 4-year-old, you can definitely do the surgery at a time that you can no longer get a good vision with either glasses or contact lenses. And then the best approach is to remove the lens, but not put a lens implant in place at that time, because it's an immature eye in the sense that it's going to grow. Both the length of the eye is going to grow, and the corneal curvature is also going to change as well. As Dr. Leroy said, it's absolutely possible when they grow older a bit, 13, 14 years of age, to put a lens implant in at that point. So that's absolutely no problem to do it at a later stage, once the eye has actually matured a bit.
So the best thing in that light is actually to make sure that your brain is taught how to use both eyes. So binocularity, the fact that you have both eyes working properly, is a much more important goal, and that's where the fight should be focused on. And whether you reach that without anything, just glasses or contacts, and then later on you do an implant when the eye has reached its full size, those are things that are actually secondary to the fact that the eye should be giving information as it should be, well focused onto the retina, so that the brain can be taught to work with both eyes. We are always striving towards that as eye doctors, whatever means we have to use to that end. And the reason for that is that we believe that if you have an accident and you lose one eye, you still have one eye left, and so it is of primary importance, I'd say, to try whatever we need to do to get both eyes up and working. So there's another question here: how high is the risk of retinal detachment after lens removal? I think Elke has alluded to that in her talk. On one study, it was about 5% or 4%.
Yeah.
There are other studies that are out. If you look at the retinal detachment risk throughout life in Marfan syndrome patients, some go up to 25%. Is that a lot? It is higher, I believe, than in the normal population. As we know, fibrillin is present everywhere in the whole eye. And so you basically should be under the care of eye doctors on a regular basis. And every Marfan patient, I find the community of Marfan patients exceptionally well informed. You all know your condition very well, which is great if you're an eye doctor. you meet intelligent and well-informed patients, you ought to be well-informed about what the risk factors are. Obviously, if you have greater eye length or axial length, as we call it, then your risk is a little bit higher. You should see it as building a house with a fixed set of bricks. And if you have to build a larger house, you have no option but to actually cut your bricks in half to have more. And so basically in the eye, it works like everything is elongated, everything is thinner. And as the different parts of the eye are stretched, so is the retina, with an increased risk for breaks in the periphery of the retina, in the anterior bit coming towards the anterior part. And that's where when such a break in the retina is caused, you have a higher risk. So there are a couple of things that you have to keep in mind. If your eye length is within normal values, normal limits, then your risk is lower, certainly. Someone who is specialized in eye disease and sees a lot of Marfan patients can help you answer those questions. So basically, when you see flashes of light and you know that there is no lightning going on, and you see less, or you see a shadow in one of the parts of your visual field, those are emergency signs for you to consult an eye doctor through emergency departments. The next question is let me see. I was just diagnosed with premature cataracts. Would love to know what has occurred with Marfan patients with that, what the next steps look like. If you have premature cataracts, you can see that in Marfan syndrome. It all depends on the quality of vision. And so if you drop below 5/10, 20/40, 6/12 vision, but you can still do whatever you like to do in life, you don't necessarily need to drive a car, that's a different situation from you being, say, for example, a professional who needs at least near perfect vision. Then you would probably be inclined to have surgery much more rapidly. And then what are the limitations in visual quality of a full lensectomy? What is the increase in the possibility of retinal detachment, both shortly after the surgery and in the long run? Let's put it this way, the risk never goes away, but it is higher in the months after the surgery. I'll see whether Elke wants to add anything to that question, to that.
Yeah, well, it depends. If you talk about full lensectomy, it kind of depends on whether you refer to just removing the lens or removing the lens and removing the vitreous within one surgery. Because the term lensectomy literally means that you remove the lens. Now you can either remove the lens from the front of the eye through the cornea, or you can remove it from the back. Now, if you remove it from the back, then you also have to remove the vitreous as well, which is the jelly that actually fills most of the eye. Now, the quality of vision will mainly depend on whether or not you're able to put some type of artificial lens in place to remove the lens, or if you're not able to do that. So the visual quality won't really depend on the lensectomy itself, but will much rather depend on which type of lens you're able to put in the eye, depending on the status of the zonules and whether or not you can fixate the lens within its normal position. And indeed, I agree. Your highest risk is going to be in the months following the surgery, because that's when you've actually, during surgery, you do exert some forces within the eye that interact with the vitreous, and the vitreous is attached to the retina on several places, including the periphery. So working on the lens will inevitably influence the vitreous and those vitreoretinal adhesions. So that's especially in those first months following surgery that you have the highest risk, but you have a higher risk throughout life as a Marfan patients either way. So it's definitely something to bear in mind if you have surgery, to be very vigilant towards symptoms that may allude to a retinal detachment.
When you see flashes of light that shouldn't be there, go see an eye doctor.
Yes.
And then in reading some of the earlier questions, there were a lot of questions regarding dry eye, some as a result of surgery. Do people with connective tissue disorders have more issues with dry eye than the general public? Is dry eye an early indicator for other health issues? The latter question is, the answer is no. Do they have more frequently issues with dry eye? It's not exactly known, I think, from Marfan syndrome that you have more of this. If you've had refractive surgery for myopia, the corneal surgery that we were talking about earlier, you may have more issues with dry eyes because you cut the nerves. It gets better over time, though. And then there's a gentleman who says, I'm 67 and had cataract surgery last spring of this year. I still have halos and my vision is not 20/20. And I've been told now I need glasses for reading and distance. I also have very dry eye. I assume that probably you had dry eyes before the surgery. And you can sometimes see that after cataract surgery, this is a little bit more extreme. But still we have fairly good drops. So I would advise to use hyaluronic acid containing drops without preservatives. And then the vision, obviously at 67, your back of the eye, the retina, is not the quality it was when you were 20. I think I don't need to teach you that. You do know that. So there might be other issues. And then the other thing is, people often think that when a cataract surgeon puts an implant in or tries to do his or her best to make it as good as possible without glasses, this is not mathematics. An eye is a biological thing, and so we try to do it as well as we can, but oftentimes for distance you need some correction. Still, it certainly is true for close by work. Why is that? Because in people younger than 40, our lens is elastic enough for us to be able to adapt. There's a muscle around the zonular apparatus that contracts when we want to read, and then your lens, in a secondary fashion, grows smaller and bigger or thicker and can focus nearby. This process is something we can't do beyond the age of 45 as we can before. And certainly if you've had an implant, the surgeon will normally always try to focus you on at a distance of 20 feet or further, and then you need an extra pair of reading glasses.
I think we have to, I think we're going to stop it there because we've got 1 o'clock now, 1 o'clock here, top of the hour. I know there's a lot more questions. So let me just, so we're going to, we have some options for people, and there's some other sessions they might be interested in. So let me share my screen and just give some people some more information here. And I think that was incredible. You guys had such great questions, and thank you, Dr. Kreps and Dr. Leroy, for all those very thorough answers. If your questions weren't answered here, you can submit them to marfan.org/E3ask, but be patient with the responses because obviously we're gonna have a lot with this summit going on. There's also a couple of other sessions related to vision and connective tissue conditions. There's one that Dr. Momini is giving on Marfan and vision issues, and Dr. Rachel Kuchti from Vanderbilt is giving one on Stickler syndrome and vision issues. We'd also love your feedback on this session, so please complete the session survey in the app. We hope that you'll visit the exhibitors in our virtual exhibit hall. They were generous to support this and make this possible for all of you. We also hope that you're really active in the community boards. We see so much going on there. A lot of people are meeting each other from all over the world, so please take advantage of that. And if you care to share what you learn on social media, use our hashtag, which you see right there, hashtag E3Summit20. So thank you all for joining today, and thank you to Dr. Leroy and Dr. Kreps for joining us from Belgium today. And thank you all, and we will see you in another session. Have a nice day.
Thank you so much. Bye-bye.
Thank you. Bye.
Bye-bye.